You can
Recording
see here,
in progress.
you can see that his aortic pressure is normal for his age, and his PA pressures are also normal for his age. And if you look at the ventricular pressures, you note that the diastolic pressure is elevated, both the right and the left ventricles, and the systolic pressure is equal in both the ventricles. So what do you make of this kind of hemodynamic data in this patient? So are we going to have any answers from the students?
Anybody, any volunteers? There's one, somebody has put up.
Manish.
Yes.
Yeah, can you just unmute yourself, Manish, and just speak so that becomes easier?
Good evening, sir. Here we can see the systolic pressure in both the ventricles is the same, while the left ventricle to the aortic pressure is systolic pressure is almost equal, but the right ventricle to the pulmonary artery pressure falls down. So since both the LV and RV pressures are same, it appears to be a large unrestricted VSD.
Very good.
And there is some obstruction at the pulmonary artery level. So it could be a pulmonary stenosis or a subpulmonic stenosis.
Yeah, very good. So that's what. So basically we are dealing with a child who has got a large VSD leading to equalization of pressures between the two ventricular chambers. And if that was the case, you would normally expect the PA pressure to be high unless there was a obstruction to the PA flows. So yeah, so you're correct. So there is a obstruction to the outflow tract of the ventricle. So the commonest scenario in which you would see this is tetralogy of Fallot, or maybe if the child is not very desaturated, you would think of a BSD with a PS physiology. So just go through these angiograms as they play. So Manish, are you going to continue reading the angiograms, or is someone else going to volunteer? So the first one, what you see is you can see a pigtail catheter, which has been positioned in the outflow tract, I would say very close to the valve, just beneath the valve. And you can see opacification of a ventricle, and you can see an opacification of the subpulmonary region, the pulmonary arteries. And after some time, you also appreciate the filling of the aorta in this patient. So, and if you're going to look at the panel below, you can see that this is a pigtail catheter which has been passed retrogradely into the ventricle. So this is a posteriorly located ventricle. This is a steep LAO view. So the posteriorly located ventricle over here is the left ventricle. And you can see this conoventricular VSD, or the VSD in the perimembranous location, which opacifies the right ventricle. So basically in any tetralogy or a VSD PS in an older child, what we need to look at essentially is the branch pulmonary artery anatomy and arborization. So that is the key angiogram. If anyone asks you to do just one angiogram, I think you would just do that. The rest of it is optional because most of the information presently can be obtained on echo. So the left ventricular angiogram is done only if you're suspecting some additional VSDs, which might not be seen or even on a color flow on echo because the pressures in the LV and the RV are the same. But you might be able to make out small jets when you give a pressure injection. And when you also give an LV injection, what you also do is you look at the aorta and you can make out the coronaries that they are filling. In this patient, you can see the RCA, but I must admit that the left coronary system is not very well filled. So one important reason why you want to look at the coronaries is to see that the coronaries don't cross the right ventricular outflow tract, because that's going to hinder the surgeon's plane of dissection. Okay, so the first angiogram when you see, so this is basically a right ventricular angiogram, and you can see that the ventricle is a trabeculated ventricle. The ventricular function is good. There isn't any significant AV valve regurgitation, and you can see the pigtail catheter over here, which is placed in the infundibulum. and you can see that opacifying the branch PAs. And so basically you look at the size of the RPA, the LPA over here. It looks reasonably good size. The RPA looks slightly smaller than the LPA. And you can see the arborization of both the lung fields, which looks reasonably good. And if you had just wait for some more time, what you notice on this angiogram is you slowly start seeing the pulmonary venous return in the levo phase. That's not very well appreciated here. So these are the essential things which you would look for in any VSDPS or a TOF angiogram in an older child. So moving on to the next slide. So as I said, now we had done a pigtail angiogram in the aortic root, hoping to see the coronary slightly better. But again, unfortunately, if you see this pigtail, it's located within the right sinus. And therefore, again, only the right coronary system is well opacified and not the left. So we need to make sure that the left system is also in normal position. So this patient, we selectively hooked both the RCA and the LMCA over here using a Judkins right catheter. And they were arising from their respective sinuses, which meant to say that they were now really crossing across the right ventricular outflow tract. So it would be okay for the surgeon to go ahead with an RVOT resection without any coronary concern. Now, if you look at this angiogram over here, this patient also has, so this was a descending aortogram. So when a child grows old, especially in a 13-year-old or an adult tetralogy or a VSDPS, if he's blue, you expect that collaterals should have developed by this age in them. And it's important to look at collaterals because they want to first flood the field at the time of surgery. Even if the surgeon manages to somehow complete the surgery, post-operatively, it's going to cause issues in terms of persistent pleural effusions, prolonged, probably re-intubations needed because of that, and prolong the ICU stay, basically. So we have to look at the collaterals from the descending aorta and also the branches of the descending aorta, especially the subclavian arteries. So here you notice, in addition to this patient has got a right-sided aortic arch. Okay, so that's again one of the associations of tetralogy of Fallot seen in up to 15 to 25% of cases, depending on the various series reports. And so you don't see too many significant collaterals which are arising from the descending aorta over here. You do see small ones, but they are probably not very significant. Now, a significant collateral is something which usually measures at least around 2 millimeters in size, that's in diameter, has got a significant pulmonary venous return from that particular lobe of the lung in the levo phase. And so 2 millimeters would roughly correspond to a 4 French, at least a 4 French JR or whatever Lima catheter, diagnostic catheter, you should be able to hook that collateral with that. If it's less, if you're not able to hook it even with a 4 French, then it's probably very small and you don't need to do anything for it. So those are some commonly asked questions for you in the exam as to what do you mean by a MAPCA or what is a significant collateral. Now over here, what we have done again is in this panel below, we have actually selectively injected into the subclavian. And you can actually see quite an enlarged rima in this patient giving rise to collaterals. Now, these are again surface collaterals. If you see, they don't really arborize within the lung parenchyma. They actually kind of fan out on the surface of the pleura. And therefore, there is no significant pulmonary venous return. So though this looks quite large, this is not really going to cause post-operative problems in terms of effusions, most likely. Now, if you look at the next angiogram, this is something, so this is again, we have looked at the Lima shoot. And again, you see that you don't have too many collaterals. Here, the Lima is not very hypertrophied or enlarged as it was on the right side. But you see, again, a small leash of collaterals from the basal portion of the left subclavian. But again, if you see the arborization, they really don't arborize much. And if you just look at that, they're all very minute vessels within the lung parenchyma. These are not surface collaterals. These are actually collaterals going to the lung parenchyma. But again, very small in size, so probably not of much concern in the post-operative period or to the surgeon. Now, this last angiogram, which you see on the right, probably would have been the first angiogram that we did, but I will maybe put it in the end because I think it's not routinely done by most cardiologists nowadays. And very few associations, which I would like to tell you. So this is basically an innominate vein angiogram that we have done. So the catheter from the pigtail is from the IVC into the RA, into the right superior vena cava, and into the innominate vein. So an innominate vein injection, a good sized innominate vein in right-sided right-sided vena cava effectively excludes a left-sided vena cava. So it's important to know that certain patients can have bilateral SPCs, especially in congenital heart disease. You can't assume that everyone just has a right SPC. And it becomes important for two reasons. One is if the left-sided vena cava normally should drain into the coronary sinus, but there are associations where in a patient with TOF, the left-sided coronary sinus may be unroofed, in which case it drains directly into the left atrium. So if the surgeon has not made aware of this, because the surgeon is not going to go dissecting into the neck and see where the left superior vena cava is, this information should have been given to him pre-op. And if you have missed a left superior vena cava, which is actually unroofed, you're going to have the patient operate, and despite a successful TOF correction, the patient is going to continue remaining blue or cyanosed. And we've had this instance, and we've had this actually happening in one or two instances, especially in small infants, where the LSPC was not picked up preoperatively. The second reason why we do this angiogram is for the course of the innominate vein. Now, if you actually see here, the innominate vein actually traverses above the arch. So if you see, look at the bifurcation over here, the ascending aorta would come over here and the arch would come here, and the innominate normally goes above that. Now, an important association in patients with TOF is something which we call as a retroaortic innominate vein, in which the innominate vein actually passes under the surface of the arch and inferior to it. Now, this is, of course, not of any importance to us as cardiologists, but it's important, or the surgeon might benefit from this little bit of information because it helps him plan SPC cannulation.
Just this thing, coronary sinus definitely will be dilated, no? If there is a LSPC draining into coronary sinus.
So, yeah, so if it is an LSPC draining into a roofed coronary sinus, it would be dilated. So if you're going to pick up an LSVC on the suprasternal views on your echo, but you see the coronary sinus is not dilated, that is when you think that the LSVC is actually unroofed. And you have to confirm it by giving just a saline contrast injection into the left arm. If you just give that, you can see immediate opacification of the LA. So it's important to pick that up pre-op. We have done this angiogram. I mean, this patient anyway did not have any of that, but this was just for completion's sake to demonstrate a good sized innominate vein and an RSPC. But it's helpful to go through this in adult TOF catheterization so that you don't miss an LSPC, even if it's there. So having finished that case, now any questions from students, or shall we move on to the next case?
One question in the chat box, Patil, you can just see.
Yes, sir. I think, how about end diastolic pressure?
Yes. So if you looked at the end diastolic pressures in that patient, it was elevated. Now that is something which is inherent to long-standing uncorrected TOFs. And this is being recognized very early on. We even have studies with CMR which support a lot of myocardial fibrosis, which sets in as early as 2 years of age in children. So in an adult TOF, the ventricle is going to be hypertrophied, the LV is underfilled, and you have fibrosis already which has set in. You cannot do anything even if you correct this TOF at this age. He's going to continue to have diastolic dysfunction. It might improve to some extent, but that's not a contraindication to TOF correction. Any patient who is cyanotic should be offered a TOF surgery, even if he's up to 40 years of age. Beyond that, of course, things are debatable. But if you see, this is something which is inherent in these ventricles, and the only way to actually prevent this is to do a TOF correction at the right age, which in the present day would be anywhere between 3 months to 1 year of age, if the branch pay anatomy is good. So you should not be waiting beyond 3 to 6 months for a TOF correction.
I think one more, I think that's all. Should we discuss it? Somebody has written here. I think he has already discussed it about.
So we'll go to the next.
Yeah.
Okay.
If left, another question is, sir, if left SVC is missed pre-op, can it be uploaded post-op percutaneous?
Okay, that's a good question. Now, how are you going to gain? Okay, so the thing is, if it's an unroofed coronary sinus, you might be able to occlude it post-operatively. Now, the only issues with this is, usually if your LSVC is big sized, your RSVC is either of the same size or it's sometimes smaller. So if you go and occlude the left-sided superior vena cava, you're going to have a period of cerebral venous congestion, which can complicate the patient in terms of cerebral venous congestion and sometimes cerebral edema or even venous thrombosis in this setting. So that's something the surgeons also would not want to do. So the corollary to that is, most surgeons would not be comfortable even ligating the LSVC in this instance. they would somehow actually try and put in an interposition graft or somehow reroute that LSPC back into the right atrium by forming the roof.
Thank you. And you can go ahead with the next
So the next case is a 22-year-old lady, and she was diagnosed with a congenital heart disease since childhood, but has not been evaluated properly and has not sought treatment. And she came to us quite recently, in fact, last month. And she had a grade 2/6 amid systolic murmur in the left first and second intercostal space. And you can see her saturations are normal. So we're not dealing with any kind of an Eisenmenger over here. But I just want someone to interpret this cath data. So basically, I mean, it's just basically two pressures in the great arteries, if you see. So the aortic pressure is somewhere around 100/40, and the PA pressure is somewhere around 90/40.
Any exercise oxygen saturation has been seen?
There was no desaturations on exertion.
Even on exertion. Okay.
Yeah.
Any volunteers, postgraduates who can interpret? What about S2 in this case?
The pulmonary component was loud of the second heart sound.
Ejection click?
There was no ejection click.
Patient. Hello.
Yeah.
Pulmonary PA systolic pressures and the diastolic pressure, mean pulmonary artery pressures are high. So the lady would have pulmonary arterial hypertension.
Correct.
And could be primary pulmonary arterial hypertension since the P2 was loud, as sir said, the P2 was loud and there is no ejection click. Probably the age also fits into primary pulmonary arterial hypertension.
Okay. Now, did you notice something which is quite striking in this patient was that if you notice her aortic pressure, she has got a pulse pressure of 60. So that's a wide pulse pressure. Would you expect a wide pulse pressure in primary pulmonary hypertension?
No, that is not common in primary. That is not seen in primary pulmonary hypertension.
Yeah. So
also congenital heart disease since childhood.
Yeah.
And what about the lower limb saturation and other things?
It was 98% in all the four limbs.
Oh, 98%.
Okay.
So what do you think it is? Your opinion, postgraduate.
Okay.
Is it still...
If someone who has got a congenital heart disease in childhood, that's a clue.
Okay.
And
PDA with PH.
Yeah. PDA with
PH. Sorry.
Correct.
I didn't look at diabetes.
Yeah.
PDA
So,
with PH.
yeah. So if you see here, the diastolic pressure is still low. So what does that really suggest to you with regards to the PDA? I mean, I agree the PA pressure is high. The PA pressure is equisystemic.
Yeah.
Do you think the PDA would be still shunting left to right, or would it be shunting bidirectionally, or would it be right to left?
Yeah, since the aortic diastolic pressure is low, the PDA could be shunting left to right only, sir.
Yeah, so there is a runoff basically.
Yeah, exactly.
So that's what is causing this wide pulse pressure. Now, the important point for you guys to note here is that the diastolic pressure of the aorta and the PA and the systolic pressure of the aorta and the PA are almost matched. So if you see, there is only a very, I mean, this might be even with some recording issues, but 190 is like almost the same, and 41 and 39. Okay. So I'll show you another tracing once I finish discussing this case. So the important things here are you've got equalization of the systolic and the diastolic pressures in this patient. So there is a PA and aortic equalization with respect to the systolic and the diastolic pressures. So the PA diastolic pressure also continues to remain low as much as the aortic diastolic pressure continues to remain. So your diagnosis was right, and this was an angiogram which we did. So conventional views which we take are a left lateral angiogram. And in case we cannot see the PDA very well, then what we would do is we would take a right anterior oblique, say somewhere around an RAO 30 degree.
RAO 30.
So if you see here, the first angiogram, you can see a large PDA. Now, this quality of this angiogram is not bad. In fact, we've given sufficient ml of contrast, almost 30 ml.
Yeah.
But this is something which we encounter if you do adult PDAs with such large shunts, because the volume is not really enough. There is a lot of blood which flowing into the PA and the contrast gets diluted. So basically this, and the catheter you can see actually kind of flipping into the PDA towards when the power injection starts. That's because of such a large duct. But the duct is, I think, very well appreciated on the RAO view over here down. So again, entering into the PDA there. So now we decided to close this with a duct occluder. So this was a 24 by 26 mm PDA duct occluder which has been deployed. And this is the angiogram, final angiogram which has been done after the device has been in position. And I'm just giving you now some more information over here. And I want you to tell me whether are you okay with this information that I have given you. That is basically, I gave you a pre-procedural echo detail which said that the left heart was still dilated. And so were the branch PAs. The ECG shows a normal axis. There are biventricular forces, but still features of LV volume overload in the form of Q waves in V5 and V6. With all this data in mind and this device position and the previous hemodynamic tracings that I showed you, and with the saturation of 98%, how many of you would actually go ahead and release this device, or would you want some more information? I think the person who...
I just want some more information.
Yeah.
While we occlude the PDA, and then we have to see the diastolic pressures of the LV, since he has become a little old, because when you just directly close it, so underfilling of LV can cause pulmonary edema sometimes. If it is a huge pulmonary, if it is a huge PDA, and if you suddenly occlude the PDA in a relatively old lady, sometimes underfilling of LV itself can cause pulmonary edema.
It's not really too much to do with underfilling, but anyway, I'll come to that aspect later. There's something else. Would you want to look at something else before you actually look at the LV and the LV EDP? Is something else more important? Don't you want to know what happened to the PA pressure in this patient?
Asking PVR, PA pressure, all these things.
PA pressure
Has been given already.
So this is what is the tracing once this PDA was occluded.
Yes.
So you can actually see that the curves which are actually superimposed have now widely separated. So this is the aortic pressure trace. You can see that the aortic pressure has gone up to around 120 by 80. The systolic pressure has gone up. The pulse pressure is now normal. And the PA pressures have fallen to 40 by 14. It's almost 1/3 of what it was. This clearly shows that this PDA was still operable despite this lady surviving with such a large PDA to 22 years. So these are certain exceptions we come across. We really don't know the reasons why certain children develop PDOD within the first few months of life. But you have some adults with such large PDAs who have, who are still operable at this age. So that's still an enigma. We really don't know what are the mechanisms which give rise to early onset PAH in some. So this is something I want you to note, that you have to have a fall in the PA pressure when you occlude any large ductus. There is no definite guideline per se, but in any case where you feel that the ductus can be closed with other, clues to suggest operability, like a dilated LV, a normal saturation, just being a left to right shunt, ECG and X-ray being favorable, you need to have a drop of the PA pressure by at least 50% from what it was to start with. And here it's like literally fallen to 1/3 of the aortic pressure. Now, coming to your second question of pulmonary edema, what happens in most of these PDAs when you suddenly occlude this, you have a large runoff from the aorta into the PA. Now, when you suddenly occlude the PA, this aortic runoff is gone. So that leads to an increase in the aortic diastolic pressure and the aortic systolic pressure. So basically what gets activated is something which we call as the Nicola-Doni sign or the Branham sign. That happens with any large fistula as well. So you see hypertension and bradycardia in these patients the moment you occlude a large duct. And that reflexly causes an increase in the systemic vascular resistance. Now, this increase in the SPR and the aortic pressure is something the left ventricle is not able to accommodate because there was a period of runoff all these years. So the sudden increase in the afterload gives rise to an afterload mismatch, which causes an increase in the LV end diastolic pressure, and the LV can actually start dilating and even become dysfunctional. So it's important to look for LV function. Most of these patients on table, you will notice immediately on echo that the LV has started becoming dysfunctional. It would not be very bad. It would stay somewhere around 35 to 40%, but you need to keep a watch on this. What we normally do is start them on some ACE inhibitors to try and reduce that afterload mismatch. And especially in children, we can see that in the next 1 or 2 weeks, their LVs are back to normal, and then we take it off. In adults, sometimes we might need to keep them on ACE inhibitors for around a month, and some may need a small dose of diuretics as well. So it's important to look for this pressure tracing and the separation. Now, the reason why, so if you have any doubts on this, otherwise we will move on. Now, just a small point with regards to operability of a PDA. Now, calculating the QPQS in a PDA is having a lot of errors. One thing is because in such a large PDA, usually what happens is the PDA flow itself is directed towards left pulmonary artery. So when you look at oximetry runs over there and even the pressure data, the ideal way to obtain a PA pressure in these instances is to actually go distally into one of the branch PAs and not keep it at the mouth of the PDA, because you might actually be hitting the jet might be hitting the main pulmonary or left pulmonary artery if you're there, and your catheter can actually record aortic pressures. You might think that the PA pressure is very high even in moderate sized ductus, but it might not be. So preferably get into one of the distal pulmonary arteries, either the right or the left. Now, if you're looking at saturations again, because the PA is angulated more towards left pulmonary artery, you might actually have a higher PA saturation. So you can't just take an LPA saturation and use it for your PV minus PA when you're calculating the oximetry. So preferably, if you're planning to do that, we don't routinely do that anymore with oximetry for PDA calculation. We basically go by the hemodynamic data and the pressure drop. Then we deal with large PDAs. But if someone still wants to do that for an academic purpose, I think it's preferable to just take one sample in the RPA and another one in the distal LPA and average the two to get the PA saturation. Any more questions with regards to this case? Then we'll move to the next one.
Then go to the next doctor.
Yeah. So if you recollect the first slide, I told you that the aortic and the PA diastolic pressures were equal. Now this is a tracing. I just brought this up not to discuss the hemodynamics further in this patient, but just to